Good evening, everyone, and apologies for the minor setback that we've had. A bit frustrating, that is, but that's technology for you, or maybe I'm not too sure what I'm doing. But what we'll do is we'll do a quick review in terms of what we discussed last week, and then pretty much crack on with it and take it from there. So last week we had a brief discussion about the introduction to anatomy. We also discussed about the thorax, and what I actually want to or intend to do today was actually to put that into practice now. That's the main thing that we have to do, is all the knowledge that we have is how do we actually put it into practice. So obviously, as explained last time, these webinars are not there to replace your learning, and we'll be discussing that later on today, what I actually mean by that. These webinars are touching literally on what's out there, what's actually on the surface of some of these clinical areas. So just keep that in mind, that this is not there to replace your learning, but it's just there to give you a brief introduction of certain topics. And I'm trying to get you from A to Z a bit quicker than the time it's taken me to get from A to Z. There's no reason for you to start reading, for basic things about histology and cytology and so forth, and start doing, human dissection. But obviously, the more that you learn, the more you can build on that knowledge. And we'll be touching on that today briefly, and I'll be giving you some examples. So if we discussed, obviously, the learning outcomes, what to expect from the lecture itself. We described what is anatomy. We discussed the key terminology. And what I tried to make clear at the time was that it's really, really important to make sure that you get your heads around some of the anatomical terminology that's out there. And that's because if you pick up a textbook regarding anatomy, you're not going to be able to understand it if you don't know the terms. And if you don't have a good understanding of anatomy, it's hard to build on that knowledge. You can't go on to learn about physiology, which is how these structures function, without you having an understanding of how to name these structures, what these structures look like, and their function. For example, if we had a car and we started to discuss, okay, how do you actually get these cylinders causing combustion? Without you understanding what a cylinder is and what it does, you're not going to understand how that combustion works. So the same thing with the human body. You have to be able to name parts, you have to be able to locate parts, and you have to be able to understand what their function is. Then you can go into physiology and learn, why they do what they do. So anatomy can be studied in various ways. Gross anatomy basically means looking at anatomy from a perspective of what you can see, whether that involves dissection or just literally, looking at certain parts and defining them. Microscopic anatomy is where we're talking about histology and cytology, and this is a discussion on a cellular level. Just remember that everything happens on a cellular level. Nothing happens on a macroscopic level. The result of the cellular processes is what happens on a macroscopic level. So that was a summary. We discussed about the anatomical position. Just remember, this is the anatomical position. If you're not sure, just memorize it. It's literally palms facing forward, feet forward, head forward. This is what we will always use to describe. This is not the correct orientation. This is not anterior. This is posterior. And I gave you an example last week of the importance of making sure that you have the definitions the right way around. I explained to you where if you're not able to use the correct orientation, how things can actually go wrong. And that was a summary slide there. We then divided the body into certain planes, which are quite useful. In actual fact, when we're discussing next week, I believe we're doing abdomen, this is going to be really, really important, because we're going to actually divide the abdomen into different planes, and you'll have different regions. For example, you'll have the epigastric region, you'll have the umbilical region, your hypogastric region, you'll have the left hypochondriac, right hypochondriac, left lumbar, right lumbar, left iliac fossa, right iliac fossa. And when you're actually discussing this and actually putting these structures into different areas, you have to be able to identify these different planes. Again, I'm not going to spend time going through this again. You can listen to the lecture. It's available on YouTube, but just do get your head around the plane itself. Anatomical terms, quickly, anterior means facing forward, posterior means facing backwards. Again, look at the anatomical position that he's in. We also have words like superior, inferior. We never actually discussed superficial or deep. Go on Google, quickly search it up. Superficial normally tends to mean structures that are more towards the actual surface of the body, and deep normally means structures that are normally deeper into the body with a reference point. For example, quite commonly you'll hear that the facial artery is superficial and runs superficial to the masseter muscle, which is a muscle that you find in the cheeks. And that's how they describe it. What it's basically saying to you is that the facial artery is actually on top of the masseter muscle. That is quite relevant. For example, if you were doing let's say you were doing a filler and you had a needle that you were inserting inside the jawline here, you would need to know that actually that facial artery is superficial. What that means is that if you're going to have a needle that's going to be going pretty much to the surface of the skin, there's a chance that you're going to go through that facial artery. And that only anatomy teaches you by understanding what's superficial and what's deep. But we can touch on this a bit deeper, but I'm not going to spend hours discussing that with yourselves. Again, we then had a summary slide. Let's now get into the thorax. So what is a thorax? The thorax is the medical term for the chest. It is made up, I've got 3 constituents. Actually, it's made up of 4 constituents. You have the sternum, which is known as the breastbone. You have the costal cartilages. You have the ribs. And behind here, we have the vertebral column. You will always use these terms. Breastbone is only used for patients. Spine is only used for patients. You will call it the sternum, and you will call the posterior portion, or behind the sternum, the vertebral column. And this is the anterior view. Keep that in mind. So let's break this down then. Ribs. We have 12 pair of ribs. The ribs are composed of costal cartilage, and they're composed of actual ribs itself. Costal cartilage or ribs are connective tissue. If you're not sure what a connective tissue is, just remember that there's around, I think, 37 trillion cells, and these cells that have similar functions go on to make tissues. Tissues then go on to make organs. Organs then go on to make systems. And bone and cartilage are a special type of connective tissue. So there's 4 major types of tissue. We have connective tissue, we have epithelial tissue, we have nervous tissue, and we have muscle tissue. And these are then broken down into separate components. And you need to get your head around this, and I'll put some information out there later on in the MedLearn group to explain this to you. But just remember that bone and cartilage are a special type of connective tissue. And connective tissue literally connects stuff together, and you can see how the bones are connecting things. Whereas nervous tissue and muscular tissue are separate, but bones are a type of connective tissue, and you'll come across this. But anyway, true ribs are those that connect directly in the sternum. We can see 1, 2, 3, 4, 5, 6, 7. These ribs are directly connecting in the sternum. False ribs are those ribs that don't connect in the sternum. You can see that the ribs 8, 9, and 10, 8, 9, and 10 actually connect to the 7th costal cartilage. You can see here, they connect to the 7th costal cartilage. This then connects onto the sternum. That's why they're called false ribs. And ribs 11 and 12 are floating. You can see they don't connect onto the sternum itself. Intercostal spaces is going to become a lot more relevant today, and that's this space here. In between the adjacent costal cartilages and ribs, you have a space here. We've got first intercostal space, second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space, sixth, seventh, eighth, ninth intercostal space. Intercostal means between the ribs, and that's going to become relevant later on today. We then discussed this briefly about true, false floating ribs. We then went on the spinal column. You can divide the spinal column into different regions. You've got the 7 cervical spinous processes, which is basically the small protrusions that you get off the spinal column here. We've got 12 thoracic vertebra, which is the small bones. If you were to count it, actually, you've got 1, 2, 3, you've got 12 tiny bones. that come off the thoracic. The lumbar has 5. The sacrum, the reason why we call it fused is because if you actually do dissection and have a look at the actual sacrum itself, it's actually one bone, but it has 5 tiny little protrusion or processes, and that's why we call it, there's 5, but they're fused. Same thing with the cortex. Would you ever get like a discharge summary of a doctor or anyone saying T4 had herniation? That's what it means. It means that the 4th thoracic vertebra had a herniation, which basically means that the vertebra contained fluid, and that fluid had escaped, and it was at T4. So if you ever come across that T7 was damaged, L5 was damaged, C7 was damaged, that's what it means. You've broken down the vertebral column into separate sections. That's all it means. And again, this was all explained in the first lecture, so do listen to it because we don't have time to go through that again. I then divided it and showed you the different parts here again. And now we start on the sternum. This is the most important thing you have to remember. So I'm going to spend some time on this, and it's really, really important you get your head around this. The sternum or the breastbone is broken down into 3 parts. You have the manubrium, the body, and the xiphoid process. Why we call it a process is because any bone that has tiny bone that actually pulls off it or protrudes off it is called a process. And you'll see it everywhere. You'll see the acromion process, you'll see the spinous process, you'll see the xiphoid process. All that means is that there's a bigger bone and the tiny projections, we call them process. The body of any bone is the biggest part of the bone. And you can see why we call this the body, because it's actually the biggest part of the sternum itself. So the sternum has 3 parts: manubrium, body, and the xiphoid process. This is the joint. When the manubrium connects to the body, we call this the manubrio-sternal joint. That is a very important landmark. That is the most important landmark when we're talking about the thorax. And I'll get into that in a second. So we've got to get our head around this. We've got the manubrium, we've got the body. There's a joint. A joint is where you have 2 bones that articulate. The word articulate means connect. So where we have the manubrium connecting to the body of the sternum, we form the manubrium-sternal joint. And I'll explain to you why that's important in a second. So this was the breakdown of the thorax. We've got the ribs. You have the manubrium, or the sternum, sorry, which actually contains the manubrium, the body, and the xiphoid process. And you have the spine. And if we have a look, that makes the thoracic cage. So I'm going to go backwards, and now you'll know what the thoracic cage is. It contains the sternum, right here, the ribs, and behind here, you have the vertebral column. Now let's talk about practicality and what this actually means. So ultimately what you're thinking is you've taught us a lot of science or anatomy. We can now label parts. It's quite smart. If a patient comes in, oh wow, that's the sternum, or that is the that is the costal cartilage. What does it all mean? Why should I learn these terms? This is where, get a pen and paper and jot this down. Now, in order for us to relate structures that are external to internal, we need to have reference points. Without reference points, you're not going to be able to relate the structures that are external to internal. You don't have the luxury of doing surgery on every single patient that walks in. Let's say a patient walked in and you thought, okay, this patient might have possibly pathology in the lung. How would you know exactly where the lung is? How can you precisely locate exactly where the heart is? In order to do that, we use landmarks. These are basic areas of the body that relate exactly to what's underneath. We can pick certain points in your body and they relate to exactly what's underneath. the body. We can relate the external structures to internal structures. And that's how we are able to utilize this knowledge I've explained to you. The sternal angle is formed when the manubrium connects to the body of the sternum. What that forms is a ridge. This is going to be really difficult to explain over a webcast, and that's why we have the actual learning lectures. But basically, if you want to give this a try, if you feel where the Adam's apple is, and you can attempt to do this, and you run your fingers down the Adam's apple, you'll feel that in between, as you keep running down, you have like this depression. That depression is this, the suprasternal notch or the jugular notch. That is where you have your trachea is going right through that notch, that opening, that notch. As you keep running your fingers down, you'll come across a ridge. And again, this can only be shown if you can, I'm going to ask Bobby if he can hear me, actually, if he can see me. Bobby, can you see me?
I can, yeah, thank you.
Okay, perfect. Okay, so let me try to explain this to you. So if you run your fingers down here, Bobby, is that quite clear? Can you see me? Like, is it big enough, the screen? Can you actually see this?
I think if you could just enlarge on the screen.
Let me enlarge on the screen. Okay, let me enlarge. Oh, it's gonna get messy again. God. Okay, maybe I shouldn't try to play with this. Okay, where am I going?
You're larger than you were.
Okay, well let's try it. I mean, as long as, again, we're going to be doing it on the actual days itself. I'll try to explain this. But anyway, here's my Adam's apple right here. I can feel it. If I keep running my finger down, I will come to like I don't want to use medical terms. I will come to like a depression. Let's call it a depression. I can feel actually that there's a pipe that's fitting inside this little area. Think of a pipe that's going in this area. And as I start to run my fingers down even more, literally in line with the Adam's apple, I will come across what we call a ridge. And again, we're going to explain this to you on the day itself. But that ridge is a bump that's formed because of the joint of the sternum connecting to the body. And you get like what we call like a bump. Why that's relevant is because right next to that bump is your second costal cartilage. And that is your reference point to be able to count ribs and then to be able to identify structures that sit here. So we're going to be explaining this on the day, so don't worry if you can't find it. But by identifying this landmark or this bump that you'll be able to feel, right next to it is your second costal cartilage. When you can feel your second costal cartilage, in theory, you can walk down and count the various ribs. The reason why you might ask, okay, why don't we count number one? The reason you can't count number one is because the clavicle, which is the collarbone, sits on top of the first rib, and it's really difficult to feel or palpate. So we can't use that as a reference. So the reference that we use is that if you can find this bump, which you can feel on everyone once you're shown, it's really straightforward. Once I show it to you, you'll feel it everywhere. In actual fact, if you started to play around just centrally with the breastbone, and really slowly, you'll start to feel like a bump. You'll feel a bump. If you keep going up and down, you'll feel a bump. Right next to it, you have the second costal cartilage. Right next to that, you have the second rib. Let's just, for now, just believe that there's this bump, and I'll show it all to you. But just imagine now we all find the bump. So you've all found the bump. Right next to it, every single person, right next to that bump, you have the second costal cartilage. Doesn't matter who you are. Male, female, doesn't matter who you are gonna feel the second costal cartilage without fail. It's impossible for you not to feel right adjacent to it. And that is the reference point we use to count ribs. Why is that important? Why should you as a clinician be able to identify this landmark and count ribs? Why do you care? Well, let's explain now. Before we go into that, why you care, something really important about the lungs. You have a left lung and a right lung, pretty straightforward. The left lung is actually smaller than the right lung because the heart sits here. If you get any picture, and I'll show you, if you get any picture of the heart, it actually sits on the left lung. If you ever see army men, when they actually, and I think you can still see you can still probably see me, when they swear to something, what do we all go? It's the left-hand side, and you put your hand here, because that's where your heart is. The heart's on the left-hand side. And you have the cardiac notch, because the lungs have to compensate for the heart that sits here. Just remember that, and we'll get into that in a second. More importantly, is that the lungs have lobes. So your lungs are divided into different areas. You have a right lung that has 3 lobes and a left lung that has 2 lobes. Why that's important is because if you have a patient who walks in with pneumonia and you do a chest x-ray, in the actual explanation, they're going to have on there that it was the right lobe that has pneumonia. It was the superior lobe of the right lung that had pneumonia. They're not just going to say to you, this person had pneumonia in the left lung. They have to be more precise. And how you can do that is you know that the lungs are divided into different lobes or different sections. The right lobe has 3 sections. You have a superior, middle, and inferior. The left lobe has 2 sections, superior and inferior. There is no middle lobe, and the reason is because the heart has to sit in there. That's why, whatever reasons, God, evolution, whatever you want to say, but that is the reason why the left lung is slightly smaller. Why that's relevant is because actually, if you ever have a patient who's suffering with difficulty of breathing, and you identify that it's a structure or there's a foreign body that's stuck inside the airway, it's most likely going to go into the right one, because the right one is actually bigger and more vertical. The right bronchus is actually bigger and more vertical, and the foreign body can easily go here and right inside the right lung. Remember that as a clinical point, that you probably won't see this in your practice, but if you were working in hospital and a child had swallowed a particular object, they would definitely first investigate most likely the right lung. Why? Because the bronchus of the right lung is bigger, it's more vertical and nicely follows the trachea, and the actual foreign particle can lodge easily in the right lung. Just something to keep an eye on, and just something to remember. So, a bit about the lungs which you need to get your heads around, and that is pleura. You probably wouldn't have come across the word pleura, but what the word pleura basically is your organs are inside a covering. The heart, the liver, the lungs, the abdomen doesn't just sit there freely. In actual fact, if you were to do dissection, you can actually pull your different organs in sacks. The heart is in a sack. Think of it literally like a carrier bag. You've got your heart in a carrier bag, your lungs are in a carrier bag, the abdomen's in a carrier bag. When I did my dissection, you could literally open up the thoracic cavity, and every single organ is in a separate bag. You can literally pull out the bag and separate the different parts of your body. And that's what the pleura is. The pleura is a lining that lines the lungs, and it also lines the wall that connects to the ribs. That's all the pleura is. In between, we have a space. So all your organs have an outer covering to protect it. The covering has a name. The covering is called pleura. That's all you have to remember. organs are covered by special tissue to protect it, and it's known as pleura. The lungs have two pleura. You have a visceral pleura. Viscera refers to organs. That's the Latin, I believe it's the Latin or Greek word for organ. And parietal pleura refers to where it's actually connecting to the actual wall itself. In between here, we have a space, a potential space. And that is what can actually happen is if you were to have, let's say somebody was to have for some reason, whatever reason, they've had an actual pathology where let's say there's been an opening made in the lung. This space here can then be filled with air. And what do you think is going to happen if you have air that fills this space? It's going to push onto the lung and it's going to cause the lung to collapse. That is a pneumothorax. A pneumothorax is where this space that's created here, you have air that fills up, that air puts pressure on the lung can't expand, and you get a collapsed lung. In order for you to understand what a pneumothorax is, you need to understand that the lung has two special coverings. Think of it as two pieces of paper. It's really a small space, it's not a major space, but there's two pieces of paper that are on top of each other. Technically that can be separated, and that separation can happen because of air and so forth, and that's the space that's created. Also because the reason why you have space is to allow your body to move. Imagine when you're running and you're going to run, your organs actually move. In order to stop them from actually colliding with each other, causing damage, your body maintains the space so you can expand areas, and we'll touch on that in a second. So just a brief summary, you've got the thoracic cage is made up of your costal cartilage, is made up of ribs. You have the lungs, there's two lungs, there's a right lung and a left lung. The lungs are divided into lobes, and the right lung has 3 lobes, the left lung has 2 lobes. The reason why the left lung has 2 lobes is because the heart sits more towards laterally into the left lobe, so it has to compensate, so it just says, okay, I'll be slightly smaller. I've also explained to you that every part of your organ, think of it inside a carrier bag. It's in a protective carrier bag. It has an outer protective cover and an inner protective cover. Then you get to the viscera, which is the organ. Because you have these 2 coverings, technically there's a space in between, and that's where you can have potential pathology can occur, and we'll do that in a second. I also explained to you about using particular landmarks, which we'll explain now. So let's have a look. If you identify the sternal angle, and that is where the manubrium connects to the body, you can see that you can actually count and know where the different parts of the lungs are. Think about it. If you could identify this structure and you could then count, okay, that's rib number 2, there's a space here. Rib number 3, there's a space here. You then know, okay, that the middle lobe will start at rib number 4. You'll also say, okay, I can now listen to the right lung, and I can know that I'm listening to the middle lobe. There's a space in between, which is known as the intercostal space. We then can go rib number 5, intercostal space, rib number 6, intercostal space, and I can listen to the inferior lobe. So when your doctor is actually listening to different parts of your chest, that's what he's listening to. He's listening to the different parts of the lungs itself. He's not just placing the stethoscope in random places. He knows exactly where he's placing it. He's trying to find out where does this person have some sort of pathology. Also, look at this space here. This space is the costodiaphragmatic recess. I explained to you that your lungs have an outer covering. And the reason why your lungs have an outer covering is they have to be able to expand. In actual fact, if you were to put your stethoscope on your eighth rib, what you'll be listening to actually is this space here. Why that's relevant is because if you've got a space, that means it can be occupied. If it can be occupied, there's a chance it could get infected. Think of all this space here. Look at all that space. There's a huge space here, and there's a space right here. A tiny space here. That means this space has potential to be filled with air and filled with fluid. If it's filled with fluid, it's going to push on to the lungs. If it's filled with air, it's also can affect, on this side, affect the lungs as well. And let's move on to the next slide, which is going to be important. So, what does your doctor actually do? Well, if he wants to listen to certain parts of your heart, he will use the sternal angle as a landmark. He will say, okay, let me find the sternal angle. If I move laterally, I can feel the second costal cartilage. In between the second costal cartilage is where you hear the aortic valve. Now I want to hear the pulmonary valve. So what I'll do is I'll again find my landmark, which is that ridge. I'll move to the left-hand side slightly. I'll then go in between the second and third rib, and I can listen to the pulmonary valve. If I wanted to listen to the tricuspid valve, again, he's going to use the ribs as a reference. Rib number 2, rib number 3, rib number 4, rib number 5. If I wanted to listen to the mitral valve, I'll go to the, normally you can see that the nipple actually is a good landmark, but unfortunately, for example, women, the nipple, the area that the nipple actually lies superiorly or to the front of the body is going to be different depending on the size of the breast and so forth. So you can't use that as a landmark. Instead, what uses the ribs. You can count and you can listen to the mitral valve. Why he wants to listen to the valves? He's probably listening to a murmur. He wants to see the heart functioning properly. Am I getting the normal heart sounds, S1, S2? Was it pathology, S3, S4? You can't just place your stethoscope anywhere and just decide that, okay, I'm just going to place my stethoscope somewhere where I can hear boof, 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 and I'll find out what's going on. It doesn't work like that. They use these landmarks. Every single person has exactly the same landmark. And you'll find exactly the same structure, unless there's some sort of pathology in the sense that, I don't know, a rib has been removed or for example, you have some people whose the heart's actually on the right-hand side. And that's really rare, but there are some people where everything's the opposite, but don't worry about that. But normally you can use this as a landmark to be able to count different areas. I'm not going to go into the heart, but let's stick to the chest. I just wanted to show it as an example of how you can use that angle, this little ridge or this lump that you can feel, use it to count ribs, and then use that for different areas to relate the external structures to internal structures. Obviously, the best thing would be if we had some sort of binoculars that we can see right through, but you can't do that. Instead, you have to use your rib cage as a reference point, and the rib cage forms a perfect reference point. Why? Because you can feel it. In actual fact, use your fingers, you can feel your ribs. Doesn't matter if you're overweight, doesn't matter if you're skinny, you can feel your ribs. You can feel most of your ribs very easily. And that's what we use to count spaces. So, application-wise, you have a patient that walks in and you feel might be having some sort of pathology in the lungs. You decide to listen to the lung. You say, okay, I'm going to listen to his lung. You're going to listen to the lungs to see if there's any sort of pathology. What you're going to do is you're going to find the manubrium. You're going to find this bump which connects the body to the manubrium, which is the manubrium sternal joint. You're going to move to the side and say that's rib number 2. I can then walk downwards and find rib 3, rib 4, rib 5, rib 6. And then you can listen to the various parts of the chest. What you definitely don't want to do is start listening to different parts of the chest or the thorax and actually end up listening to the liver. Because if you have a look here, and it's quite straightforward. Rib 1, rib 2, rib 3, rib 4, rib 5, rib 6, rib 7, rib 8. Below rib 8, there is no lungs. Do not place your stethoscope on rib number 10 or rib number 9 and expect that you're going to be listening to the lungs. You're probably listening to the liver or the diaphragm. That's really important, and I've seen clinicians do that, and that's because they don't understand anatomy. They just think, oh, that's a rib cage. Let me just stick a stethoscope there. Your ribs actually end. Your ribs end at rib 10, but the lungs don't go all the way down to rib 10. They actually stop at around rib 8. And I'll show you a picture which will make it nice and clear for you. Have a look at this. Really clear. When you're listening to the lungs from an anterior portion, which is a front on view, you can actually see that the lungs end at rib number 8. On the side, they're also stopping at around rib number 8. But actually, you can go a bit further because you have the pleura, which is the actual lining of the lungs, and that's where the lungs can actually expand into. So before we move any further, I might actually make sure this is really clear for everyone. Bobby, can you hear me?
Yes, I can.
Was there anything in there that you found might have been confusing that you'd like me to re-explain?
The only thing, you mentioned the carrier bags around each organ, which was a good analogy. Was it correct that there was only 2 of those coverings around the lungs? Everything else had 1? Or was it every structure had 2?
No.
It wasn't quite clear.
It's a bit confusing. In actual fact, it's actually 1 layer, but it folds over itself. The only way I can explain that is on the Medlin group. I'll send you a picture of it.
Okay.
It's really confusing to explain without me showing you a picture.
Okay.
It actually, what happens is, and it's hard to explain, it's when your body is actually forming, so you go through the different germ layers, the mesoderm and endoderm, ectoderm, and so forth. What you find is actually that the organs will actually come out of this layer and fit inside this layer, and it's actually 1 layer that folds over itself. It's really confusing, but I'll send a picture. It's going to be difficult for me to explain to you, but clinically, the only thing that you have to remember, clinically speaking, is that for the lungs, you have a pleura. Visceral pleura refers to the lining of the lungs to the lung itself. Whenever you see the word visceral pleura, that means that this is referring to that lining that actually is literally on top of the lung. Yeah?
Okay.
Parietal pleura refers to that lining that actually attaches to the actual chest or the actual rib cage, and in between there's a potential space.
Okay.
The reason why you have a space is because your chest has to expand, and that's why you have this space here, because every time you expand, the chest has to be able to expand to fill up with the air. It can't stay static. Think of it like a balloon. Yeah. When you pump air in the balloon, it has to expand, and your body does exactly the same things. It allows it to expand, and in between here you have fluid. Yeah. So your body's easy be able to allow that lung to expand, and you've got fluid in between. That's the only part you've got to understand for now. And in terms of pathology, if you were to get something like air in between those spaces, that can impact the lung.
You mentioned the sternal angle and being able to identify that, which is fine. I can feel it actually, so that was very clear. You mentioned the second rib. The ribs are different in everyone, aren't they? So finding the sort of intercostal space, do you actually feel for it, or do you just sort of estimate it around?
You feel for it. You feel for it. Literally what you'll do is you'll feel for the sternal angle, which you found. And again, if you go on a YouTube video, you'll find it. And again, we're going to explain it in the sessions anyway. You'll feel for the angle. You'll move left or right, and you'll feel your first or your second costal cartilage. Can you still see me?
Yes, clear.
And literally what they do is that you'll go second costal cartilage, I'll walk down and I can feel a space. I can feel my space here. Then I can feel the third rib. I can feel like a space in between. And then I can feel my fourth rib. Literally, you count down like a ladder. You literally put one finger here, second finger in the space. Then you move using your second finger as a reference point. You go then move right, literally adjacent to it. You'll feel the third rib, and you keep counting downwards. Keeping in mind that your ribs angle, so you have to move at an angle. And that's how you count the spaces.
Right, okay. You mentioned the pleural cavity as well.
Yeah.
You hear a lot about pleuroseat. How do you actually check for that then? Because you're not checking the pleural space with the stethoscope, are you, particularly?
No, you can't. No, you're not. That's right, you're not. That requires X-rays, and that requires different CT scanning, MRI. No, you're not. The only thing that you need to be aware of is when you're doing stethoscopy, just please make sure you don't put your stethoscope on rib number 9. You're not listening to the chest. Sorry, you're not listening to the heart. Oh, sorry, your lungs. You're listening to probably the liver. That's the most important thing to remember, is don't put your stethoscope in the wrong place. You need to know that the ribs, that the chest itself, at about rib number 8, that is it. Don't go below that. Don't use your ribs or the rib cage as a reference point that the entire rib cage is made out of. It covers the lung. It doesn't. Your rib cage also protects your heart, and it protects your liver. Your body's quite smart because it's also protecting, and I'll show you a picture, it protects different parts of other organs purely because it's just evolution and the way it was designed, because it understood that that is a painful area. In actual fact, if you see boxing, when they punch on the, on the right air, they go for the liver. Why? Because some of it's exposed and it's extremely painful.
Yeah.
But the ribs do protect it.
Okay. Is that the purpose of the floating rib?
Sorry?
Is that where the floating rib comes in, or is that
No. The floating ribs have nothing to do with this. They literally just float. They don't do anything.
Right.
They're just there. That's just, that we don't actually understand what their purpose is, but they're just there. They're just known as floating ribs, but they don't really, they don't actually do it. They're just there. Okay. But the rib cage itself, and I'll show you another picture. This will make it a bit clearer. Can you see that picture?
Yeah.
Yeah. Can you see this brown here?
Yeah.
This is representing a bit of the abdomen, the cupula of the abdomen, which is basically the cupula actually means like a dome. So your abdomen, and we'll be discussing that next week, has 2 domes. It has a right dome and a left dome. Okay. And you can see how the liver actually sits just inside and protects it here as well. And this is why when we start to do actually physical examination, you might have seen doctors actually feeling for the liver. And what happens is when you breathe, when you're breathing, everything gets pulled down, and that's how you can actually feel for the liver, because the liver will descend as well.
Okay.
And that's how you're using this as a landmark. What you'll actually do, you'll feel for the costal margin here, and the costal margin here, which forms the opening, and then you'll realize actually that is where, once you breathe, you can actually feel in some people the liver. Not everyone. You can't feel the liver for everyone. I can't feel mine, but certain people who are quite skinny, don't have thick abs, you can probably feel for the liver itself. And if they've definitely got pathology like an inflamed liver, definitely when you put your fingers on the actual abdomen, and when the liver descends, they're going to get ouch. You'll actually feel it. In actual fact, when somebody comes in with pain in the right quadrant, and you want to feel for possibly an inflamed gallbladder, you can actually feel it. They're going to get ouch. If they've got like inflamed gallstones, or they've got a gallbladder that's inflamed because of a stone, you can actually feel it. Again, you're going to be using this as a landmark. Did that make sense? But that we'll be discussing next week. That's not relevant. But for now, what's relevant is you knowing that the ribs, look at that picture, perfect. 1, 2, 3, 4, 5, 6. Look how the angle 7, 8. That is literally where your ribs, where your lungs are ending.
Yes.
Anything below that, you put your stethoscope on rib number 9, rib number 10. You're listening to probably the liver. You're not listening to the lungs. So please, when we do get into this practically, don't put your stethoscope in the wrong place, because you're not listening to the lungs.
Got it. Thank you.
Perfect. Yeah. Let me ask. Assalamu alaikum, Abdul. Abdul, can you hear me? Okay, that's not worked. Let me go to Michael. Michael, can you hear me? Michael? Okay, it's being awkward. I'm not sure. It might let you speak. So what you need to do next in order to become good at this is Abdul, can you I think he's gone now. Abdul, can you hear me?
Hello, Fahim. Hi, how are you?
Assalamu alaikum, Abdul. Are you okay?
Islam, not bad. Thank you. Yourself?
Is there anything that's not clear for you that I've tried to explain that's maybe a bit confusing?
No, so far it's been clear cut. To be honest with you, I've apologized. I actually joined a little late, but so far it's been great. Thank you.
Fine. So you understand that the main thing is that there's, you've got you've got one pair of lungs. Yep. One is slightly bigger, one is slightly smaller. You understand that the right bronchi is bigger. So if you ever have a patient who might have something stuck or has a foreign body, it's most likely to be in the right one. And the reason for that is it's bigger, and the actual tube itself really nicely follows the trachea. So objects can nicely go inside there.
Fine.
You also understand that actually that the lungs have this covering, and I won't confuse you, but the lungs have this covering that's known as a pleura.
Yes.
Okay. There's an inner pleura that's known as a visceral pleura, and that covers the lining of the liver, the lining of the lung. And we have an outer pleura that connects on the actual thoracic or the actual rib cage itself. In between, there's a space.
Fine.
In between that space, there's normally liquid. Why it's liquid? Because if there wasn't liquid, can you imagine what would happen to the two linings? They're just going to rub on each other. Yep. If you start to rub on each other, you're going to start getting pain. Remember, I've not even discussed about nerves. It's going to get too deep, but I'm not going to even go into nerves. But you've got nerves. You've got somatic sensation, and you have autonomic nervous system. And this is a bit deep, but we won't go into this. But this is why when the pneumonia gets quite bad and it extends to the pleural cavity, that's when the patient actually feels pain. You don't feel pain on visceral cavity. You don't feel pain when the pneumonia is actually only around the visceral pleura. The reason is because you're not supposed to feel different sensations of your organs. Like, for example, when you eat food, you don't actually feel your gut working, do you?
No.
You're not supposed to, because your gut does not give you that sensation. It's not sensitive to touch. It's not sensitive to light. It's not sensitive to pain. It's not supposed to be. For example, when your body changes blood pressure, you don't feel your smooth muscle contracting or relaxing. You don't feel that. You're not supposed to.
Correct, yeah.
There's a reason for that, is because if you started to feel every single sensation in your body, it would be quite awkward. It'd be really, really weird that you could feel every part of your body. The only things that you can feel is more different nerve endings, that are more superficial. And that's why when you get pneumonia that expands or starts to go towards the pleural cavity, that's when the patient will have pain.
No, definitely. Thank you. Yeah.
That's clear? No questions?
Yeah.
Okay,
No, it's fine.
so
Thank you.
Move on. I'll quickly ask a couple of other people, then we move on to what you need to start doing practically and how I got better at this. So thank you for that. Michael, I think eventually it's going to allow you to hear. So when it does allow you to talk, do let me know. And you can ask the question. Imran, can you hear me? Okay, so Imran can't hear either. I won't ask Liana. Philip, can you hear me? It's being awkward again. Assalamu alaikum, Shazli, can you hear me? Okay, in any case, it's just being awkward. So if it does allow you to talk, do let me know if you've got questions. Oh, Shazli, assalamu alaikum.
Wa alaikum salam. Yeah.
Can you hear me?
Hello?
Yeah, assalamu alaikum, Shazli, can you hear me?
Yeah, I can hear you. Yeah.
Is there anything I've mentioned that's not clear to you? I know you didn't get the chance, for whatever reasons, unfortunately, to attend the first lecture. Was there anything in this that was not clear for you that you'd like me to explain?
No, it was all quite straightforward. It was fine. Yeah, it was good.
So you understand that? Brilliant. Thank you. Brilliant. Okay. We'll move on then. If it does allow anybody else to speak, Michael, if it allows you to speak, do let me know. I'm actually getting some questions, I think, which I'll get to in a second. Chat. So we have. Okay, fine, perfect, Philip. You can hear everything. It's clear. Great. Okay. So how do you become good at this? Okay, what you need to do is really straightforward. First of all, buy a stethoscope. You don't need to spend more than £100 on a stethoscope. Please don't do that. Maximum is £100 that you want to spend. And I would go for Lippmann. Lippmann, who's the one that I had, and I went with cardiology number 3. But that was because it was quite sensitive to being able to listen to heart sounds and murmurs and all sorts of funky stuff. But basically, get a Lippmann stethoscope, Lippmann 1, Lippmann 2. It's about 100 quid. That is what you need. So buy a stethoscope. If you're not sure, get in touch. Don't just waste your money, please. Don't start spending hundreds of pounds without just, if you're unsure, just check with me. Buy a stethoscope. If you've got the money and you're going to buy an electronic stethoscope, that's even better because you can record sounds. And I'm doing that for the students. So then when we do start doing the short cases, you'll be able to actually listen to chest sounds and so forth. So rule number 1, buy a stethoscope. Secondly, what you need to do, which I think is quite smart, every time a patient that walks into your pharmacy with any sort of chest pathology, pneumonia, bronchitis, ask them, can I listen to your chest? That is free learning for you. Every single time a patient walks in with clarithromycin or walks in with amoxicillin or doxycycline and says, I've got a, what are you using this for? I've had a cough and so forth. Ask them, can I listen to your chest? Start to do one person who has a normal chest. So listen to friends, listen to family, listen to your own chest, and then start to listen to patients. And you will start to realize the difference in what we call vesicular versus, probably pathological or bronchial sounds or different types of sounds. That is free learning for you. You don't have to do any commitment. You've not had to make the prescribing decision. You just get to freely listen to people who've got an infection and get to learn from it. That is what I started doing. That is what I started doing with everything. With otoscopy, every time a patient comes in and the doctor prescribes Otomize, I get my otoscope, I look in the ear. Okay, that's otitis externa. Fine, makes sense. Okay, you're suffering with otitis media. Do you mind if I can just have, and patients love it. Believe me, patients will absolutely love it. Michael, can you I think it's allowing you to speak now. Can you hear me?
Yeah.
Do you have any questions?
No.
Perfect, brilliant. Did you understand by what I'm trying to say about making the best of this learning of just asking patients as they come in? Do you understand the benefit of that?
I do, yeah.
It's absolutely free learning for you. You get the luxury of listening to their chest without actually having to make a prescribing decision, and you get to learn. And what you want to start doing is, the most important thing is listen to chests that are normal first. You've got to know what normal is. If you don't know what normal is, you cannot listen to someone's chest who's got an infection. You won't know the difference. I would set your target of 2 chest sounds a day. 1 chest sound that's normal, your staff, family, friends, and 1 chest sound of a customer that walks in that has some sort of chest pathology. Listen to it. You will start to learn. You'll start to hear wheeze. You'll start to hear crackling, because you can ask them, what did the doctor diagnose you with? Oh, he diagnosed me with pneumonia. Okay, fine, you had pneumonia. What were your symptoms? I had a fever. I had chest pain. You just got free learning. That's pneumonia. That makes sense. Okay, so you had chest pain, you had fever, you had a temperature. What was your temperature? Let me go measure it for you. Oh, 38. Fair enough. You had chest pain. Tell me a bit more about your symptoms. When did it start? It started 5 days ago. It started as a cough. You've just learned free learning, and you've got to listen to his chest. And you take that same aspect and start doing it on people who come in. I had a patient today, actually, the first time I saw, well, I won't say the first time, but I haven't seen a perforation in a long time. And she had a perforated ear. She came in saying, I've got pain in my ear. So I did a consultation. She paid £30 and I had a look. And she had a perforation in the right ear. There was actually a hole there. I prescribed her ciprofloxacillin, and the reason for that was, because of the reason I didn't go with like Otomize, or I didn't go with Celludex, is because when you have a perforation, there's a chance that you can get ototoxicity because of the aminoglycoside. Just remember that there is contraindicated. If you have a perforated eardrum and you prescribe them an aminoglycoside, they can get ototoxicity. So ciprofloxacillin was what I prescribed, the eardrop, siloxane. And I got to, if I was learning, that would be amazing. If the doctor prescribed it, I just got to see what a perforation looks like. Just because I asked her, can I have a look at your ear? Now, I've seen it before, but if you've never seen it and you had an otoscope, you get to learn for free. You get to learn for free and get experience that, okay, that's what it looks like. That's how you get good at this. You've got to start seeing normal versus abnormal. And you start applying this to all the different cases. Eventually, you get such a massive pool of knowledge that you've seen it all without you having to take the risk. Because when you make that prescribing decision, you're taking the risk. Remember that. Also, going back to being able to count rib spaces is when you're doing percussion. So what we can do actually is, in order to make sure that your lungs are not pathological, you can actually percuss. If you don't know what percussion is, it's literally where you're using your fingers and you're tapping on the different surfaces of the body to listen to different sounds. If you go to a wall and tap on the wall, if it's a solid wall, it's going to sound like a dull sound. If it's hollow and there's a potential space behind it, it's going to sound like it's hollow. That's exactly the same concept that you use when you actually start to percuss, what we call basically when you start to percuss the chest. What that basically means is you have a patient that walks in and you start to tap on the chest. You know that the chest is normally hollow, so it should have a hollow sound. You start to percuss on the chest and you feel a dull sound. And you're in the right place. Remember, if you start to feel at rib number 10 and you percuss, it's going to be a dull sound. Why? Because there's the liver there. Be very careful. Don't start. Again, if you don't know your landmarks and you start, oh wow, there's a dull sound there. There must be something that's making it dull. Are you definitely actually tapping on the lungs, or are you tapping on the liver? But just imagine you were in this space here and you tapped here and you felt like a solid dull sound. And we'll explain this in the training courses. You then know actually that there must be something causing this solid sound. Is it because she's got fluid? Or is it because, God forbid, she's got some sort of lump or a cancer? That's why doctors will use their fingers and do this. Tuck, 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 tuck. What they're listening to is that sound. They're listening to that sound. If it's a hollow sound, perfect. That's what the lung should sound like. If it's a dull sound, something's not right. I probably don't recommend doing this on patients, on every patient that walks in. You probably won't appreciate this. But start off with a stethoscope. Buy a stethoscope. Start listening to chest sounds. For those people on the MedLearn group, I'm going to post the actual lecture itself out there, so you can you've got a copy of the lecture. And by doing that, you can start to listen to the right places and get free learning. That's exactly how I did it. We're running slightly over, but we did start slightly late. I just want to quickly touch on how to take a history, just briefly, because it's so important. A patient walks in with a cough, comes to your pharmacy, he approaches Michael or he approaches Imran or Bobby or myself, and he goes, I've got a cough. The first thing that you need to know is the differential diagnosis. You have to know what the differential diagnosis of a cough before you can even go in to take a history. There is no point you asking that patient, when did you have the cough? When did the cough start? How long have you had it for? Without relating it to the various disease states. If you think this patient has TB, you would ask, are you getting night sweats? That's a relevant question to ask. Please don't ask questions without understanding why you're asking them. You cannot make a diagnosis without relating it back to the history. That's why in the Medlearn group, I was trying to encourage everyone that it's really important to make sure that when you have a symptom, you know the differential diagnosis. Then you ask the history of the presenting complaint. Then it makes sense. How long have you had the cough for? Ooh, I've had the cough for 7 weeks. If you've had a cough for 7 weeks, that is no longer an acute cough. That could be, God forbid, some sort of cancerous cough. That's why the doctor asks, how long have you had it for? If the doctor asks you, are you having it when you cough? Is it painful? When you're breathing, is it painful? Yes, it is, because if it's pain and you're coughing, could it be a pneumonia? If he says, no, it's not painful, fair enough. Is the cough, when did it start? Did it start literally suddenly, or did it start over a period of time? If it started suddenly, it could be left ventricular heart failure. I hope I've made it clear. What I'm trying to say to you is you cannot take a history without knowing your differential diagnosis. You cannot start to ask people random questions without you asking. Ask yourself, why am I asking that question? If this patient comes in with sore throat, why are you asking him, is it difficult to swallow? Why do you care? So what if it's difficult to swallow? And what? It's because you know the differential diagnosis. I'm trying to confirm if this patient if it's difficult to swallow, is it tonsillitis? Is it possibly, is it, for example, what's it called? Is it some sort of abscess? Is there something trapped in the mouth? This is why you're asking the question. You're not randomly just asking people questions for the sake of it. Otherwise, what we can do is I can get a bunch of questions and a 5-year-old can ask them. I can ask them every time the patient has a cough, ask these questions. He or she will gather the data. Then what happens? What do you do with it? Why are you percussing? Why are you randomly just putting this patient through this procedure where you're going to get your fingers and starts tapping on his chest without you knowing that the reason I'm percussing is because I'm trying to find out if the sound is a dull sound or if the sound is producing what we call a resonant hollow sound. If it's a hollow sound, thumbs up. Great. Sounds good. If it's a dull sound on the chest, ouch, something's not right. Why? Because the chest shouldn't have a dull sound. Why? Because there might be some sort of mass. It might be fluid. Okay, fine, might be fluid. Let's go further forward. Tell me your symptoms. I've got a cough. When I breathe, it's painful. I've got a temperature. I've got fluid. What do you think it is? Might be pneumonia. You do not have the luxury of doing aspiration, sending that piece of kit to a lab and diagnosing that person's got pneumonia. That poor person might die of, you might die of community-acquired pneumonia. You have to make a clinical decision. If you can't take a thorough history and relate that to differential diagnosis, you're wasting your time. You're going to make a mistake. You're going to hurt someone. That's why it's absolutely important to make sure that when you are taking a history, you understand the differential diagnosis. Without the differential diagnosis, it's a waste of time. You're wasting your time, you're wasting that patient's time. That is the art, that is the skill to this. Asking a bunch of questions just for the sake of it without you relating it to something is a waste of your time. So we're going to be touching on that more in the Medlearn group, and that's why I was trying to encourage you that, okay, this 30-year-old patient, this patient comes in with chest pain. What are your differential diagnosis? So we know that the chest and the heart are linked. You always need to have two systems that you're going to be examining. Chest pain could be possibly GORD. Chest pain could be some sort of lung pathology. Chest pain could also be myocardial infarction. How do you break it down? Is that chest pain radiating? Why are you asking it's radiating? The reason you're asking it's radiating because you're trying to link it to some sort of heart disease. Why are you asking the patient, can you just actually tell me exactly where it is? Is it around this? Is it here? Or is it here? Because if he goes, it's around here, you can say, that might be good. So when you're questioning someone, think of yourself as an inspector. You are verifying, and you're also trying to make sure the history is correct. I hope that's clear, because that's the most important skill that I've learned. when the doctors kept telling me, Fahim, it's all in the history. Everything's in the history. I never understood what that meant. I'm asking the questions. I've got a book. Here's a book. I've got McLeod's. I've asked him all the different questions, but I don't know what to do next. He's got a cough. He's had it for 3 weeks. It's painful. He's got a temperature, and what? That's what I used to get stuck, because I never knew the conditions that relate to it. So you can learn all these different skills of how to percuss. I can listen to chest sounds. Why are you listening to his chest in the first place? Because you think it might be pneumonia, you think it might be left ventricular heart failure, you think it might be DB, you think it might be a pneumothorax. That's why I'm listening to his chest. That's why I'm asking these particular questions. I'm trying to narrow out my differentials. Left ventricular heart failure, pneumonia, upper respiratory tract, lower respiratory tract. Let's say, for example, he's got a cough and the patient goes, when I lean forward, I get pain here. You listen to his chest and you realize actually there's nothing on the chest. If you're leaning forward and you get pain here, sinusitis. Sinusitis should ring a bell. Upper respiratory tract, it's not lower. I've listened to the chest, I've listened to the chest, I've ruled it out. He might need some antibiotics. That is the kind of rationale behind it. So have a look at the slides. If you've got any questions, just send them on the chat. I'll stay around for a bit. We'll start on the free learning, 2 patients a day. 1 normal chest sounds, 1 pathological chest sounds. Start learning. You get to get free learning. In terms of buying a stethoscope, do ask me, and we take it from there. I think we'll call it a night now. And if you've got any questions, just leave it on the actual chat. I'll wait for 5 minutes. I'm happy to answer. I'm happy to discuss. And again, apologies for the start. Have a wonderful evening. Have a wonderful weekend. And next week, we're going to start on the abdomen. And take care, everyone. Thank you. Bobby, you can hear me?
Yeah, got it.
Good.
Yes,
What's the question?
Okay. Differential diagnosis, you related to just a minute ago. What's the best text I can use to cover that?
Okay, Symptom Sorter.
Symptom Sorter.
Buy that book.
Let me write it down.
Let me show you here. You can see the video. This book, Bobby, is what I use. Yeah.
Yeah. Okay.
And it's amazing. Just have a. You'll be able to see it. Can you see it?
Yeah, a little bit. Yeah.
So what it says is every single symptom, for example, chest pain, it will give you the common differential diagnosis, occasional differential diagnosis, and rare differential diagnosis.
Right.
That is what I use. It's impossible to memorize everything. So if I was to go to the eye, an acute eye, it will tell me the differential for acute eye are acute conjunctivitis, acute iritis, acute glaucoma, keratitis, corneal abrasion.
Right.
Occasional are episcleritis, keratoconjunctivitis, trauma, orbital cellulitis, and it gives you the rare. And it tells you the different investigations, and it breaks down quite nicely how you differentiate between them. That's a really good question, because the truth is you can't search on the net for everything. This is perfect. The only thing that you got to keep in mind is make sure that you definitely pay attention to something that's going to end somebody up in hospital.
Okay.
That is what I never used to do.
Yeah.
Does that make sense to you?
Perfect. Yeah, no, it's good.
If somebody comes,
sometimes too many options. Yeah.
Yeah, if somebody comes in with an acute red eye, please make sure you rule out orbital cellulitis. It might be rare, but if you don't rule that out,
Yeah.
he's gonna lose an eye.
Yeah.
What I used to do was the other way around. I used to always think, forget that stuff. Haha. Let me just focus on the common stuff because that's all it can be. But that stuff isn't going to get you in trouble. What's going to get you in trouble is if you misdiagnose someone with, let's say, he had uveitis.
Yeah.
Or he had, if let's say it was a cough and you misdiagnose somebody that has a shortness of breath and you misdiagnose a pulmonary embolism, that's going to get you in a lot of trouble.
Yeah.
So that's the key to it. So I'll tell you how much it is. It's £40, but it is the best book. It's the best book that I invested in.
That price has got to be, hasn't it?
Yeah, absolutely the best book. It's got every single symptom and it breaks it down to symptom, because patients, they come with symptoms. They don't say to you, oh, I've got pneumonia. What they're going to say, I've got shortness of breath. Now you sort it out.
Yeah.
Or I've got a painful ear. So if you go into ear, and it'll tell you, okay, if it's painful ear, is it a discharging ear? Is it ringing in the ear? For example, tinnitus. It'll tell you, okay, tinnitus, what's the differentials? Earwax, hearing loss, otitis media, Meniere's disease are the common ones. Occasional can be head injury, could be drugs, could be hypertension. Rare could be something like severe anemia, and this particular condition known as a glomus jugular trauma. I don't know what that is, but it breaks it down for you nice and easily.
Sure.
Nice and easily.
Brilliant. I'll grab it.
You don't have to memorize anything. Easy.
Yeah, good. Do you actually have that on your desk then?
I have it on my desk all the time.
Really? Okay.
And then what starts happening is, when you've seen the cases again and again, you'll just memorize it. You'll just know it. You don't need to you'll just remember it.
Yeah.
Where I found it quite useful is when people come in and say, I've got abdomen pain. And in the abdomen, you've got the liver, you've got the kidney, you've got the gallbladder, you've got the spleen, you've got the intestines. There's so much there, and that book breaks it down. That if it's this region, that region, bang, 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 what you got to think of. That's it. Or appendix. Imagine you get somebody who comes in with right-sided pain. You definitely don't want to misdiagnose appendicitis.
Yeah.
Boy, you're going to get a lot of trouble for that. You need to be able to diagnose that, and that book will quickly give me bang differentials. How I learned that was when I spoke with one of the doctors. I said, doctor, do you know all the differential? He goes, no, I use this book. Why should I remember all the differentials? I'm not a computer. I've got the book. And once you read it 1 billion times, you remember it. That's what GPs do. Only trouble with going on the internet is that there'll be 1,000 differentials and there'll be so many there, you'll get stuck. And that's where I found that you can get yourself in a bit of trouble with that, because there's too many. Another good website, please sign up to, I'll send the link, is Medscape.
Okay.
Free to sign up, amazing website. It gives you the workup, it gives you the differentials, and it tells you how you diagnose between A and B. I'll send that on the link. Sign up to that, it's free. Everything you need is on there.
Okay.
Thank you. Thank you, Bobby, thank you.